to SAM Conversations. I am Tarun Basu. COVID-19 has overwhelmed the global public health system. The most advanced countries like the US and Italy have been literally brought to their knees by the onslaught of the pandemic, and they're struggling to cope. In fact, US almost seems to have given up. Closer home, India has had a tough time, and India's numbers in terms of infections is among the 10th worst in the world. But its fatalities are surprisingly very low. The today morning figures are about 4,167 fatalities. And as the health officials said yesterday, that its fatality rates are still much, much lower than the global fatality rate. It's 2.87 compared to 6.45 globally. Also, there have been 0.3 deaths per 100,000 compared to 4.4 globally. Also, they claim the recovery rate is consistently going high. From 7% recovery rate when the lockdown began 2 months ago, it's now the recovery rate is about 40%, which is, if the figures are to be relied upon, are pretty good. Now, one must understand in terms of the Indian public health system, the government spends, as a lot of us know the figures, is less than 1.3% of its GDP on public health, and which is among the lowest actually in South Asia. Not just one of the lowest in the world, it's one of the lowest in South Asia. Indian government takes care of only 27% of public health expenditure compared to say 50% in China, as high as 80% in some of the European countries. I don't know about Australia. So there's over-reliance on private health infrastructure in this country. And there are a growing number of private hospitals which have come up. And in the last 10 years, there's been as much as $4 billion invested in private hospitals. So we have this thing about, government spending 27% only on public health, and largely 73% being depend on private health, private hospitals accounting for health hospitals being dependent on only 73%. And so the most poor people who cannot even afford private hospitals, they actually go and become even poorer after they go through these hospitals. So the things will have to change. And one of the main challenges the government has realized, number one, is underinvestment. So they have promised now from now less than 1.5% or less than 1.3%, the public spending, the percentage of GDP will go down to about 2.5% in the next 4 or 5 years, next 2-3 years, number one. And there will be more investment in public, training and education of public health professionals. India has found that, although there are a growing number of medical colleges and a lot of people are going into becoming health professionals, for a country of 1.3 billion people, they are woefully short in numbers. And we don't have a proper public health education architecture. So in a pandemic of this kind, does not have the infrastructure or financial capability to tackle a large public health disaster as this one. So to discuss this and much more, we have a very distinguished panel, all from the School of Public Health and Community Medicine in the University of New South Wales, one of the world's top universities. I'm happy to introduce Dr. Anurag Sharma, a health economist and co-director and master of the public health program at the School of Public Health and Community Medicine. Dr. Anurag Sharma, I would like you now to give some perspective from your perch on what is the current challenges and where do you think India can do in the next years or so to meet such challenges?
Sure, Tarun. Firstly, thanks for having me. So you have given an excellent introduction of Indian healthcare system. If I might add a few more things there. So when you said that, Indian government spends around 1.3 or 1.5% of GDP on healthcare. There was a recent study by a Princeton University, who who tried to estimate the capacity of Indian healthcare system in terms of how many beds they have. So there's not very accurate data available, but they tried their best with whatever was available publicly. And the estimate is that in a country of 1.35 billion, there are just 1.9 million hospital beds or 19 lakh hospital beds, out of which 95,000 are ICU beds. And there are around 48,000 ventilators. So you can imagine the lack of infrastructure. And not only that, interesting part is that India is formed of around 28 states now. 63% of these capacities or beds are in just 7 states. So the distribution, if you see the distribution of resources as well, that's not very equal. So there is this huge issue of access to care in terms of availability of actual physical beds. But now you come towards other factors such as quality of care in public hospitals. So as you rightly said, that individuals mistrust public hospital system in India. They are willing to go into poverty, but they try to get care for their loved ones through a private healthcare system, and which is highly unregulated, if I might say. So that's another issue. One issue is that there are, in terms of labor force, for example, there are just 0.7 doctors per 1,000 population, which is a very less the ratio, like compared to say Australia or UK or Russia, the figure goes above 3 point something per 1,000 population. Not only that, I'm just talking about allopathic doctors. So there is a huge industry of traditional medicine like Ayurveda and all, which are also now counted. But having said that, among these doctors, the good quality doctors either go overseas, for greener pastures, or are attracted by private sector. So in public hospital, you are left with a workforce, health workforce, with low morale, almost no resources, and they have to treat these patients. Now imagine on this, if the system experiences the pandemic of the scale of COVID-19, you can very well imagine its readiness. So when we talk about the preparedness for COVID-19 in India, I'll just give you a perspective. The first case came around in January end, but the lockdown was introduced almost after 2 months.
2 months, yeah.
Now, what happened there was, to be very clear, there is no scientific evidence for that lockdowns work in pandemic. There is scientific evidence that masks work, social distancing works, right? Hand hygiene works. There is a scientific evidence, but there is no scientific evidence for lockdown. Yet, most of the countries are adopting this strategy. And what is the reason? They want to buy time. They want to get prepared for this pandemic. So the idea is the sooner we lock down, we should then just start revamping our healthcare systems. Some countries argue that, temporarily we should increase the capacity to be ready for this influx of COVID-19 patients. In India, I would argue it's a golden opportunity for India, where you said, it's looking to increase its investment in healthcare. This is a golden opportunity to permanently increase infrastructure. And this is a very good way to do that. However, in lockdown, when they buy time, the effectiveness of lockdown depends on your other strategies. So first of all is revamping testing. So once you have a lockdown, you should immediately start testing You should have infectious disease surveillance strategies. You should be very good at contact tracing. You should prepare your hospitals, buy more ventilators, more ICU beds, which is not easy, by the way, given the constraints in Indian health. In India, this strategy, as whatever is available in public domain, was not effectively implemented. And what happened was, even if the data, if it was collected at all, it was not used for decision-making purposes. So main idea to collect data is you identify hotspots, probably redirect more resources to, take care of those things. Maybe you have less resources for, say, greener zones or safe zones, but that didn't happen. On that, the decision was so abrupt that there is this big issue, social, economic, cultural issue in India of internal migrants who have to walk through thousands of kilometers to go back to their villages from cities. And this was not taken care of in a very nice way. And what are we left with? There's a huge opportunity cost to lockdown. Every country is facing it in terms of the economy shuts down. The government revenues go down. In India, for example, GST brings the chunk of revenue for the government, or the fuel excise. Now the demand has gone down. So the government is literally running out of money to essentially, put it in the healthcare system. And when these migrants are going back to their villages, there was an incident in Uttar Pradesh, for example, where all 50 migrants were tested positive who reached a village. So now this will spread in the rural areas, which were more or less, the infection rate was low. Some people argue that, if we had not done this lockdown, maybe we would have much more infections or many more deaths. But if you don't manage the lockdown properly, remember, it's a public health emergency. But in India, if you see as an outsider, it seems like a law and order issue. The lockdown is treated as a law and order issue. Authorities are more interested in, policing the lockdown rather than use that opportunity to collect data on infections, come up with consistent guidelines. We don't even have consistent guidelines to report deaths. Some patient in some states, if they die and have suspected COVID-19, they don't test them if they have died.
Dr. Sharma, if I might interrupt you,
Yeah.
Your observations are very correct and to the point. And, things might even go worse in the coming months as the lockdown gets lifted and more migrants are going back to their home. But to what do you ascribe the low rate of fatalities, about 4,167 up to this morning, compared to, say, 100,000 in US and 40,000 in European countries? So what
Abrar,
high recovery rate, about now the recovery rate is as high as 40%.
Yeah, I think Dr. Abrar Ahmed can actually,
All right.
give insight into that.
So basically, there are different factors. Like, the first thing is we have very little information about this. This is a new virus, and still we are learning. Like, for example, like there are other questions as well, like why most developing countries we see like they are spared as well, like in many African countries or in many in India or many other countries, like number of cases are relatively low. So I think that the main thing is we don't have exact answer for this, but there could be some possibilities. Like, for example, one possibility is data. As Anurag also mentioned, that quality of data is important. Like, I'm not sure about India, but I know about some other developing countries. They don't have very good data to capture mortality rate, different mortality. So I think this mortality is just reported case mortality. And if you collect correct data, probably the mortality will be high. I can give you one example. Like in European countries, the highest mortality rate is in Belgium. It's very, very high. But what they're doing, they're even if somebody died due to if there is suspicion of death due to coronavirus, they also include that in the mortality. So all countries, they have different definitions for mortality, and also the problem is with the data collection as well. So this is first thing. Second, of course, there are some other issues as well, which still people are investigating. For example, age structure. Age structure is important, like in many countries, in European countries and in America, and so age structure, they have very high aging population. So the mortality
India has
is,
a very low, I mean,
yeah,
lot of young
that's why,
populations.
yeah, that's why I'm saying
I think
that,
65% is below the age
yeah.
of 35.
So I think low mortality is probably some part of low mortality could be explained due to this factor, because the COVID mortality is probably after 65, it's 80%. After 50, it's about 60%. So India and some other developing countries, they have very high proportion of young population, and mortality is generally low among that that population. And there could be some other.
Sorry.
Yeah.
Please go ahead.
And
Please go ahead.
yeah.
Yeah.
So I think there could these are multiple factors. We can't explain this with one factor. So probably some age structure is one explanation. Probably I think still I feel that there is underreporting as well. And if you include all deaths, probably due to coronavirus, so the number of deaths will be higher as well.
Another reason that is given is the widespread use of BCG vaccination in India. You know, all of us are have got BCG vaccination at birth, and they say that could one of the reasons for the high immunity in India.
So these are all still theories. Like there is no evidence to prove this about BCG vaccine. For example, like BCG vaccination uptake is very high in Iran as well. BCG vaccine uptake is very high in Russia. Look at Russia, what is happening in Russia now. So I think BCG there is a lot of debate on BCG and many studies published which shows that so I think we can say this is just a correlation. This is not a causation. And the same explanation is for chloroquine as well. Like for example, people argue that these countries are using chloroquine. Many people malaria is also prevalent in those countries. They are using chloroquine. And recently WHO actually stopped all trials of chloroquine due to high risk of mortality.
In fact, yesterday, the Indian Council of Medical Research says they are recommending hydroxychloroquine as a prophylaxis.
But WHO,
and they're saying it has given good results in India.
Yesterday, WHO actually stopped all clinical trials. I think these are all at this stage. We don't know. Maybe those are effective. Maybe BCG is effective. Maybe chloroquine is effective. But at this stage, we don't have evidence. Current evidence suggests that the most likely explanation is age structure, and probably the reporting issues. Yeah, but still we need more data. Of course, I agree.
Yeah, certainly, I get your point. You know, one of the issues that has come up in India, other than the underinvestment, is also the shortage of public health professionals. You know, there are not enough medical colleges. There are not enough colleges attached to hospitals. The medical colleges require huge investment, which are not being made by the government, but only by private sector. And so because of that, there's a mushrooming of private hospitals, which, as you know, has also, given right to a spurt in so-called health tourism in a country. Where in a country where government investment in public health is so small, there's a health tourism is a huge revenue earner, and increasing number of patients, rich patients from Central Asia, Africa, Arab countries keep coming to India's private hospitals, which have some of the best doctors in the world, for treatment round the year. So that is another aspect of it. Now, yet you have to, all of us have to remember, it's a country of 1.35 billion. This, second most populous country in the world. So whatever others are doing, India has to have that 10 times more or 20 times more.
Yeah.
So how does one meet the shortage of public health professionals? And it's not just the shortage. You can have people but underqualified, people who don't have the necessary skills. And so the necessary to have a proper public health education infrastructure, which is actually lacking in India and which is a very, very neglected area. Would somebody want to come in and talk about
maybe
this?
And where Dr. India Augustine Asante can, comment on that.
Thank you very much, Anurag. And I think this is very interesting discussion. With regards to not having, adequate number of health workers, I think it's a common problem in many low and middle income countries. India is not alone. And as you rightly pointed out, it goes back to having the right infrastructure in place to be able to train adequate numbers. and making sure that it is not just in terms of numbers, but the quality of the training is also good and meet the needs of the country. So yes, if there is one thing that COVID had really brought to all countries, is the opportunity for us to revamp our healthcare systems, because it has laid very bare the lack of resilience that we should expect from our healthcare system. And all countries are struggling with that. Of course, you might say that in US and UK, the healthcare systems were not overwhelmed, to a large extent, because we didn't see people, dying outside the hospitals. But it has been pushed to a level that many few people anticipated or thought is possible in these countries. So it's a good opportunity for all countries to ensure that going forward, we invest enough, at least in training, quality healthcare workers, because without them, there is nothing we can do. Now, training alone is not enough. One thing we've observed during this outbreak is lack of protective equipment for health workers. I'm not sure about how it is in India, but we have seen that across almost all countries, with health care workers lacking the necessary PPEs to enable them to do their job well. And the world is waking up to the reality that the bulk of these PPEs were being produced by China.
Yeah, that's right.
And when China stopped supplying, you were all in trouble.
Yeah.
So
and there were a lot of complaints about poor quality PPEs coming in from China, Italy, and many other countries. Yeah.
And if I might add to what Augustine said, that one strategy is to target specialties. So in India, we lack infection control experts and intensivists. So the government should fund particular specialties, especially in its postgraduate positions. So opening medical college has, to an extent, solving the issue of undergrad medical graduates, but there should be a targeted investment in some specialties which are required and where there is a huge skill shortage, and that's how other countries do it. The second thing I just want to quickly add is in India there is also an issue of stigma attached to person who has been infected with corona, and this is why the people are not coming forward to test themselves. And this is particularly surprisingly, a lot of it is among healthcare workers. They are exposed to this sort of discrimination, So there has to be a cultural shift as well in awareness, and Government of India is doing that, for that matter, other governments, to improve the morale of the healthcare workforce, especially the allied health workers and nurses, etc. And if I might just say, that at our school, we have already started doing projects looking at this issue, and Professor Heatherworth maybe quickly can tell you, what project she's involved in regarding the healthcare workers' experiences in Australia.
Okay, so we most of our students are healthcare workers of one sort or another, and a lot of them were over this last term. We've known that they are frontline healthcare workers in the epidemic, and these experiences that they have been going through, even though in Australia we've been extraordinarily lucky to date in terms of a healthcare system that hasn't been overly stretched, although they have really seen and have a lot of concerns about the amount of stretch and the amount of protective equipment that was available at the beginning, and the kind of changes in policies and directives and plans that have come down. So we have begun a project which is looking at their those frontline healthcare workers' experiences of working in an epidemic, because often their voices, even though we've seen quite a lot of healthcare workers talking on the media about, you know, what it's like to work in a hospital in Italy or in the UK, and the difficulties of frontline healthcare workers. But what we want to do is actually to document this properly and in a way that can be used in terms of policy making that will actually get to hear the issues that are really most pertinent to frontline workers, because they are, you know, obviously at hugely greater risk than most other people in the epidemic. Yeah, so we're doing that this term. We're doing it as both a research project and an independent study for our students. So our students are, a lot of them are keeping diaries of their own experiences, doing field notes, field journals, and we're interviewing a whole heap of other frontline healthcare workers, including everybody from hospital orderlies through to ICU specialists.
Thank you. You know, the other day, Dr. Devi Shetty, one of the top cardiologists in India, gave a very interesting insight into one of the problem issues in India, and that is, it's just not about the shortage of ventilators, shortage of enough specialists to handle those ventilators. So he said, there are about 50,000 specialists who can handle ventilators. Out of them, 50% of them are above the age of 50, and because they require a certain, you know, expertise to handling COVID workers, people over 50, they are a little wary of, you know, coming into the picture at this moment. So you are left with only about 25,000 people below the age of 50 who can handle this. Now, where does School of Public Health and Community Medicine come in, if the Indian government or, you know, some of the institutions were to say, in helping India bridge this demand-supply gap?
Yeah. Can I make a quick comment, Anurag, before you come in?
Yes.
I'm glad you mentioned the age of healthcare workers in India and how to handle, you know, ventilators and other things. I think the issue of health workforce cannot be solved sustainably if there is no concrete health workforce planning. Every country must have well-crafted health workforce plan. And your workforce plan should be able to tell you how many of the workforce, or how many of the workers, health workers, will be exiting every year, and how you're going to replace them. Most countries don't have workable, you know, health workforce plans, and they don't even know the age structure of the workforce to know who should be replaced in how many years, you know. So you cannot solve the problem without a proper workforce planning. And countries like Australia went down the route of establishing Australian Institute of Health Workforce, and they were very much involved in planning, you know, for health workforce in this country. And that is the way.
I am no public health expert, but let me confess, I'm hearing this expression for the first time. And I have not read anything in the last 2-3 months which talks about this aspect in India and whether this has been an issue at all. So thank you for enlightening us on this. Dr. Sharma?
Yeah, if I may, so in our School of Public Health, if you see, we have one of the most prestigious master's program in Australia. And just specifically looking at COVID issues, our degrees offered a wide range of subjects and courses that can help understand, not only help understand this pandemic, but come up with solutions, you know, to how to handle this situation. So most prestigious of our programs are Master of Public Health and Master of Health Leadership and Management. Recently, we have started dual degrees, which are very popular among our international students. So one is very specific to COVID-19, which talks about the management of pandemics or outbreaks, and it is Masters in Infectious Disease Intelligence. And it is very popular. So our dual degrees are essentially in 1.5 years, you can get 2 degrees. And there is an extension option to give you a 2-year package where the extension option is for a project. So like as Professor Heather was just said, the project she discussed in example how a student can take, as part of their master's degree, a project which is not only very policy relevant, but very timely as well. So this is what we do in terms of our training. We have updated courses like, how to implement any program. We have an upcoming new course offered called Implementation Science. So maybe Dr. Abrar Ahmed, who is the director of MIDI, can give you an overview of MIDI program.
Yeah, these are very new subjects to me, and it will be interesting to hear about them. Also, a quick question which you can ask. How many students on an every year do you get from, say, India and South Asia for these courses?
So India, the numbers are increasing. I think last year we had around 50 students, 50, and they are increasing every year. So we hold these India road shows, and we get a lot of interest in public health. And because our dual degree actually widen their career, prospects. So if you do a dual degree, you can apply for much more higher number of jobs. And as we discussed, there is a lot of capacity to hire not only health professionals, but health managers as well to manage the program.
Yeah, exactly. Yeah. In fact, I had occasion to talk to Dr. Nikita Butler, who's from your school, and she's also wants to get into health management. Right now, she's interning with the George Institute.
Yeah, so that is another
health management area, and it was very interesting to talk to her. And she talked about how her horizons had completely opened up after she did.
And she got this UNSW India scholarship. So we also provide scholarships to very bright students. And she's doing internship, so we have this option of international internships as well if somebody wants to pursue that. And a lot of our candidates go to like WHO students.
Okay. Dr. Abrar Ahmed, you want to come in? And I think we should be rounding up also.
Sure. So this is a Master of Infectious Diseases Intelligence is a new program. Traditionally, we have most of students are enrolled, as Anurag mentioned, they are enrolled in MPH or Master of Health Management and Leadership program. So this is a new program, and it's becoming very popular, and particularly after coronavirus, it's very popular course now, program now. So this program is
popular among students from all over the world. And are you getting a lot of inquiries?
Yeah, we are getting a lot of inquiries. The number of students increasing rapidly, but of course, due to travel restrictions, some students can't come. But definitely, we are getting even the main course of this this program is Outbreak Investigation and Intelligence. Last year, we had around 60 students enrolled, and till yesterday, we have 180 students enrolled. So,
but can you do these online? Can you do these things online? Yeah, you are.
This course is all program is available online. So basically, this program is specifically tailored for emerging and re-emerging infections. So, the aim is to provide advanced skills in public health aspects of outbreak investigation, infectious disease intelligence, prevention, and mitigation. So we discuss different surveillance strategies. We discussed different health emergencies as well. We discuss there's a whole module on risk assessment, infectious disease risk assessment, because risk assessment is really important. As we were discussing about the coronavirus, that we should do risk assessment, and early interventions are better. All those countries who intervene early, they actually control epidemic very quickly. So, and also we discussed then different control measures as well. And then there are specifically, we can have projects for infectious disease as well, and some related internships as well. So this program is specifically for those who are interested in infectious diseases, particularly emerging infectious diseases. And lastly, as Anurag mentioned, that you can take this course alone, like Master of Infectious Disease Intelligence 1-year program, or you can take it as a dual degree as well, with Master of Infectious Intelligence plus Master of Public Health, Master of Infectious Intelligence plus Global Health, Master of Infectious Intelligence plus Master of Health Management and Leadership, and you can add an extension component as well to make it to a degree. So this is a very flexible program, and particularly
Okay.
for those who want to get some advanced
All right.
knowledge.
Dr. Sharma, do you want to round this up in terms of what the school can do in future post-COVID to collaborate with India and Indian institutions in terms of not just pedagogy, in terms of, but also in terms of research and in terms of larger institution to institution collaboration or even government to institution collaborations, and what India can gain from collaboration with your school?
Yeah, so we are fortunate enough and lucky that, you know, we already have established links, not only with the government of India, but prestigious institutes. So our head of school, Professor Rebecca Ivers, you know, is an expert, world-renowned expert in injury prevention. So she actually, you know, liaises with PGI Chandigarh, you know, researchers there, AIMS Delhi. We have now affiliated, George Institute is affiliated with UNSW, and it has its own physical presence in Delhi. And via that, we hold a lot of, you know, interaction with policymakers in India. And Nikita Batla, you mentioned, she's doing her internship there.
Yeah,
And
internship
most
there.
importantly, you know, we are part of, like, currently working on a project on health technology assessment. So the Indian government is
Health technology assessment, yeah. Okay.
Health technology assessment, you know, so like if you want to purchase an equipment in India, like affordable ventilators, you know, so who decides the price of it?
Wow,
Or
that's so
procurement
interesting.
price or technology. So those sort of courses. But I also want to add quickly that, you know, another very popular option is Masters in International Health, or which is now renamed Masters of Global Health, which Indian students are very interested in. And Dr. Augustine maybe very quickly give you a introduction of that program as well as we leave. You are on mute, Kojo.
Yeah, sorry. Yes, I'll be very quick with this. The Master of Global Health, it is currently Master of International Public Health, but we are just finished renaming it. So from next year, it will be Master of Global Health. And the main things that we focused on in this course are key things like what we are experiencing now, the COVID crisis. You know, the infectious disease part is very, very significant, but there are other issues too. For example, we have started talking about who will get access in case we get a vaccine. You know?
Sorry, could you repeat that?
Who will get access?
We've started talking about access to vaccine. If we are able to get, you know, to get a workable vaccine, which country will get access to it? You know, how are we going to make sure that every country, or poor countries especially, get access to this?
Okay.
There are a whole lot of other issues of international concern that we take on in the Master of Global Health, and it revolves around equity and making sure that we don't leave anybody behind, and there is fairness and justice in global health issues. The other thing is global health governance. We've all seen how it has played out in the recent World Health Assembly. You know, the argy-bargy between the US and WHO and China, you know, and all the politics going on behind the scenes. These are all very pertinent issues that countries should be able to deal with, both within their own borders and externally. And these are the things that we take on in the Masters of Global Health, in addition to other issues.
Okay. I think we must now round it up. We have had a very interesting conversation, and we have actually gone beyond our allotted time. But I think it just shows that there was so much to discuss and so many takeaways from it. I'm very grateful to Dr. Anurag Sharma for organizing this and for finding the time for it, Dr. Abrar Ahmed, Dr. Augustine Asante, and Professor Heather Worth we maybe in a month or so, or maybe we could talk again and revisit some of the issues that we talk about, that talk about need for greater public investment, that talk about health governance, so many new courses which could be very useful to people in our part of the world, in India and South Asia. I've learned so much about health, the health technology assistance, for example, the intelligence for, being able to forecast diseases in advance and things. So thank you all so very much for your time and for your interesting perspectives, and hope also some of you can at least maybe able to write these down in short articles which we can publish in Indian media and South Asian media. Thank you all so much and have a good day.
Thank you, Tarun.
Thank you.
Can I ask you one question before we leave?
Sure. Yeah.
So I want you to guess the state. So this is a state which invested in its public hospital system since 2005, increased the spending. This state's population is 35 million, much higher than of Australia's, and area is 0.5% of Australia's. It had its first, it had a Nipah virus outbreak 2 years ago.
Kerala,
it had its very first outbreak of coronavirus in January when a medical student from Wuhan came there directly. Till now, it has just less than 10 deaths and less than 1,000 infections. It has controlled that. So can you guess what state it is?
Kerala.
Kerala. So all is not lost. You can do that.
Absolutely.
It is in India.
Absolutely.
And what we discussed, Kerala has proved that. People trust their system and they learned from their Nipah outbreak. And they were very good in contact tracing, revamping their testing, isolation, quarantine.
And high rate of testing. Very high rate of
testing. So one can follow that model. I know it's not easy to implement it in states like Uttar Pradesh, which has like population of whole Europe, but still. So my point is, that what the issue with us, we have some evidence of that working.
But I don't know how many of you know, Kerala is probably the only communist government in a democratic country in the world. So
I won't go in politics. I think they switch. Every term.
Only functioning communist democracy in the world. So there's a lot of oxymoron aspects in that.
Yes.
Well, on that note, we can talk about this in another session. Maybe we can just talk about Kerala, or I can have some public health experts from Kerala join this, which will be very interesting. And thank you all so much, and have a good day.
Thank you very much. My pleasure. Bye.